Right. Good afternoon, everybody. Wonderful to be back with you again after my personal long absence with my sabbatical. Great to be here. And thank you to everyone who have who has come. It's wonderful to have you here. Today, we've got a really exciting session, something that we don't see every day, but that if you recognize this condition, you're not only going to make a difference to an individual, but probably to a whole family. And we've got some really fantastic people with us today, and I'll introduce all of them in a moment. As you can see, the topic is hereditary hemorrhagic telangiectasia, previously called Osler-Weber-Rendu syndrome, and one of those conditions that's always at the bottom of the list of bleeding disorders, but which is also much more than a bleeding disorder. So just to remind you that the recordings of the weekly Monday deep dive sessions are available on the Blood SA website. You'll find it under Resources Deep Dive. Please take part. This is our meeting. This is for all of us to enjoy, to learn from. Please add any questions to the comments or chat box, and we'll address them as we go along. If there are any of you who are not yet on the mailing list and who depend on the link that we send on other WhatsApp groups, please email Melanie. You can see her address there, and she will put you on the list. Now, there's CPD points attached to all these meetings. They are automatically submitted to the HPCSA for each individual if you are from South Africa. But that also means that if you're attending, you need to attend on your own, with your own registered Zoom account, not as part of a group if you need the CPD points. So just take that into account. There's no other way we can, if they audit us, that we can prove that you were here. If you're from another country, then also email Melanie for your own CPD certificate. Those who are from South Africa don't need to do anything. Please also provide your feedback to us at the end of the session. The feedback is anonymous, so we can't respond to individual requests, but we can use the information to try and update, improve and update what we do. I want to acknowledge and say thank you again to our team. You can see Estelle and Gerdien and Melanie there, who organizes these weekly meetings, and I can assure you it's a lot of work to make sure everybody is onboarded, that the topics are organized, the speakers, everything. And I want to say a big thank you as well to every division around the country and all the private units who have been such an integral part of making these sessions a success. This is the agenda for this afternoon. Dr. Elzaan Janse van Rensburg will give us an overview of HHT, followed by a brief presentation by Dr. Edwin Deetlefs on HHT in the gastrointestinal tract, followed by Prof. Marius Coetzee, who will speak to HHT in practice, the University of the Free State experience. And I think I'm going to introduce our speakers now, and then we can get straight to all the talks one after the other as we go along. So first, Elzaan. Elzaan has been working with us here at Groote Schuur as a medical research officer and has done fantastic work both in the HHT arena, where together with Gerdien, they've been seeing most of the patients with the support of our fellows, and she's presented her undergraduate thesis at the International Cure HHT Conference in Croatia in 2017 on this topic already. She has co-authored a poster, and she's also presented at other conferences as recent as 2022, again at the International Cure HHT Conference with Dr. Barnard. And she's a strong HHT advocate. She's done a lot of work in terms of management of these patients. And in particular, I want to acknowledge her for her work in getting the multidisciplinary team to work together and to get everybody onboarded together with Prof. Berg. And she's currently initiated an important trial or planning an important trial with Prof. Darlene Libbe. I don't know if Darlene is with us yet, but I want to specifically acknowledge Darlene for incredible work on our HHD patients in the ENT department. That's Elzaan. And of course, I need to say that she's a rock climber and a sailor as well with her husband. Edwin Dietlefs did his medical training at the University of Pretoria and specialized at UCT in Groote as a gastroenterologist, and is in private practice here in Mediclinic Milnerton. He's got broad experience in gastroenterology and liver disease, but has a special interest in inflammatory bowel disease and anemia that is obscured and not of clear origin. And we look forward to hearing from Edwin on his experience and his specifically on HHD in the gut. And then Prof. Marius Kutsia, who's someone I've worked with for 12 years when I worked in Bloemfontein. He's given us a very modest summary of his work. Marius has got extensive experience in bleeding disorders. He's one of the pillars of hemophilia treatment in South Africa and von Willebrand's disease. And together with his colleagues at the University of the Free State, they've been building up experience in managing HHD. And he's also involved with the short learning course that is offered by the University of the Free State in patient blood management. Marius is also an expert in iron deficiency and iron treatment. Marius, really great to have you here as well. So, sorry for that. Without further ado, I'd like to hand over to Elzaan, who will share with us an overview of HHD. Thank you, Elzaan.
Thank you, Prof, for that introduction. It's quite an intimidating arena, the deep dive, but thank you for the opportunity. And hopefully we can all learn together today and hopefully prompt some good discussions. If I can just confirm that everyone can see my slides and can hear me well.
Yes, we can. Thank you.
All righty. Okay. So as mentioned, we're looking at HHD today. They're not so rare after all. And I just want to start with a quick overview of the things I'll be looking at this afternoon. So we'll start off with 2 quick cases with some family issues. And then we'll break HHD down, look at the criteria. We'll look at some of the presentations, the genotypes, the phenotypes that you might come across. Also look at some complications that you might find in these patients and why it's important to look out for them. We will speak about quite a bit about the management and why it's so important to pull in the whole multidisciplinary team. And I just want to highlight some crucial principles in the management of these patients, especially also from the hematological side. And then I'll have a quick summary. And then we'll look at some resources that providers can access, but also for patients and to help the patients. Alrighty, so this is quite a complicated slide, but I want to dive into this family because they're quite complicated in their history, but this is a wonderful case to illustrate the complexities of the disease and one of the few diagnostic dilemmas that you can face with this disease. So we start with our index patient, patient R. He was born in 1950, quite a young lad, was quite all right until around the age of 18 when he presented acutely with severe hemoptysis. At that time, they didn't know what they were dealing with, so they somehow got it out, and he had a partial pneumonectomy at that age. Not a lot of differential diagnoses were on the table at that point. He wasn't fully worked up. And by the time in 1979, they sort of made the loose diagnosis of HHD, but never fully screened him for all the manifestations in all the different systems. And he's also had subsequent endoscopic evaluations at that age, and he's also had continued epistaxis and telangiectatic lesions. He went on to get married, and then in 1984, they had baby M. And this little one had quite a bit of trouble already early on. He had some delayed milestones. He presented with quite a bit of fatigue, even at the young age of 6. And then mom had some suspicions, took him to the GP. They did some testing, and then it came back with occult bleeding. And he was scoped at the age of 6, and they found 21 polyps in his colon. At that point, some advocated for a complete colectomy, but luckily they opted not to, and then performed serial endoscopic evaluations, and they continued to find polyps in this little one. Other than that, throughout his adolescence, he had repeated epistaxis, he had telangiectatic lesions, and also some migraines, but not fully ever screened and investigated for all of them. It was quite isolated management at that time. So then in 1992, they had baby L, and this little one was quite all right initially. And then based on the family history of patient R and baby M, they scoped this little one at the age of 6, also found polyps, not as severe and as extensive as baby M, but then they continued surveillance endoscopically in this little one as well. She was also found to have hypermobility and a mitral valve prolapse. She was actually initially only diagnosed with Ehlers-Danlos syndrome, but that didn't last quite a bit of time. And then unfortunately, come 2010, baby M passed away in hemothorax after some scuba diving in the morning. And then on post-mortem, they found to have baby M to have pulmonary AVMs at that time. And then on further investigation, the clinical diagnosis was made in his sister at the age of 19 in 2011. And then fast forward a couple of years, only in 2018, at that point, the attending physician thought it might be a good idea. It was actually the gastroenterologist at that time to send away the family's genetics. And lo and behold, they stumbled upon the SMAD4 gene mutation. And for that family, then the genetic confirmation was then given. So throughout that period in time, they had telangiectatic lesions, they had epistaxis, the index patient developed iron deficiency anemia, and then there was a spot of adenocarcinoma as well in the history. Some also thought that the pulmonary AVMs might be pulmonary emboli. So just a quick poll, if you guys want to take part. If you were seeing this patient or this family as attending physician, which systems would you thought to be good to investigate? I can have a couple of seconds for that. Okay. Righty. Okay, so quite a lot of different systems to think of, and quite a bunch of interesting responses. Alrighty. So a lot favor the stomach and the bowel and the liver. Some prioritize the blood, and then I see the pulmonary coming in as well. Okay, so that's quite a broad investigation, and that's quite a good way of approach. So we just have another patient's family. This is an 18-year-old lady currently in our clinic. She presented acutely at the age of 6 with hemoptysis initially. She was called at Red Cross. She also had increase in migraines, and then when she came to GSH, we thought it well to repeat her scan in 2022. We found new AVMs that were large enough for intervention, and she was subsequently coiled in December of 2022. She had improvement of her migraines, but I wanted to highlight as well, this lady had iron deficiency without anemia, and her epistaxis were quite self-limiting. In comparison to mom had recurrent epistaxis, actually had a septodermoblasty on the right. She has ongoing iron deficiency anemia that requires intermittent IV Cosmofer. She also had multiple AVMs with multiple coiling procedures, but mom is also quite comorbid. So just some key points in the history of these two patients' families. So for the SMAD4 family, the diagnosis was made loosely in the index patient initially. There was no screening offered formally for the patient's children or the siblings. And initially it was quite an isolated approach, which quite unfortunately made a major adverse event for this family in baby M dying. And there was quite a diagnostic delay. With regards to the AVM family, they highlight quite well how it looks different even within the same family. And the phenotype becomes more apparent and more severe with time. So what is HHD? It's autosomal dominant genetic disease with 50% inheritance then, only from one adult, with a prevalence of 1 in 5,000. That number is unfortunately not represented by national data that we have currently, but we are working towards that. It's characterized by the telangiectatic lesions and the arteriovenous malformations. The diagnosis can be made either clinically based on the Kurosawa criteria or genetically, which is available in South Africa, more so in private, but it can be accessed in state. The management is multidisciplinary, always. That's the buzzword for this disease. And it's often underdiagnosed, also with a diagnostic delay, which one of our colleagues, Dr. Jenny Barnard, nicely illustrated in her MMed project as well in our cohort. With regards to the Kurosawa criteria, there's 4 aspects. It's our Cure HST colleagues internationally that came together in 2000 back then. They said we need something to base our clinical diagnosis on. They looked at the spontaneous recurrent epistaxis, the telangiectatic lesions at characteristic sites. This includes the nasopharynx, the GIT, the skin, the lips, especially the oral cavity and the tongue. The visceral regions you can find in the lungs, the liver, and the brain, and sometimes as aberrant blood vessels in the abdomen. And also the presence of a first-degree relative. So this is then a definite diagnosis if you have 3 or more, a possible clinical if you have 2, or unlikely diagnosis if only 1 is present. But I cannot emphasize enough that this is limited in the young population and the pediatric population. If you can just appreciate the natural history of this disease, it alludes to becoming more apparent the older the patients become. So HST has quite a couple of friends that it tags along that you can look for in your patients, either clinically or on history. They might present with migraines, typically with aura, if they have a significant shunt. Some of them can have septic emboli that's establishing themselves as brain abscesses, and that's how they might present. They can bleed, they can stroke. Some of them develop quite short of breath, especially in exertion. If the right to left shunt is quite significant, they can become clubbed. It's quite rare, but they can. They can have hypoxia and even hemoptysis, as you can see, as some of our patients actually presented initially. If their iron deficiency anemia is quite severe, they can develop failure. And also if they have some severe symptomatic liver lesions, they can become quite strained cardiacally. And then they can also develop pulmonary hypertension. Some of the SMAD4 patients can develop aortic root pathology, and they can also present with melena and polyps. So just with regards to the genetics, there's 3 most common genetic mutations, but it's not limited to these 3. There's quite a lot of ongoing research with regards to the genetics, and they still have a lot of question marks. But the most common ones are the HST type 1, which is the ENG encoding for the endoglin, and HST type 2, which is the ACVRL1 gene encoding for ALK1 receptor. So endoglin and ACVRL1 are membrane receptors on the endothelial cells. And then you get the SMAD4 gene mutation, which is a mutation of the transcripting factor intracellularly. And this accounts then for what you see clinically for the juvenile polyposis and the HST overlap syndrome. On the left-hand side, you can appreciate that endoglin accounts for the majority of cases at 54.5%, whereas the SMAD4 only accounts for 1 to 3%. This has some clinical applicability when it comes to what they might be more at risk with regards to lesions, but it does differ. And all of these mutations form part of proteins involved in the tumor growth factor in BMP pathways, and they are important for the angiogenic balance when it comes to angiogenesis together with vascular endothelial growth factor. So this is just to show you or to make you aware of the typical history you can find in the HST patient and what their lifetime might look like. So, and this just highlights again the limitations of the criteria. You can appreciate in ages 0 to 20, they tend to be quite asymptomatic unless they present with a severe adverse event, and that's why screening is so absolutely crucial. They can maybe get some telangiectatic lesions as they become older into the adolescent time. And then by the age of 40, 90% of patients will have epistaxis, and quite significantly so. And their iron deficiency anemia becomes more difficult to treat, and they might become asymptomatic or symptomatic from untreated AVMs. Also in these patients, they become comorbid, they enjoy their metabolic syndrome diets, and then they become difficult to manage. So just a quick poll again. If you would have to see this in your daily practice, what would you think it might be? If we can maybe just have a quick idea of what will your first diagnosis be. Let's give it a few more seconds on the results. It'd be interesting to see what everyone thinks of this one. Alrighty, and that's sort of what I expected. It looks very much like a cannonball lesion, I agree, and that which in case would be a malignancy, and I did see some points for the vascular ones. But actually, this is a wonderful X-ray of a arteriovenous malformation. And then you can appreciate the lateral on the right-hand side. So this is quite rare to find them like this, but this one was quite significantly enlarged and complex with multiple feeding arteries. So it can sometimes trick you on a chest X-ray as well. On this side, you can just appreciate how it might look on the CT chest. There's quite a large AVM on that side with a feeding artery that would be probably significant for intervention. On the right-hand side, I would like to illustrate what you might see on a transthoracic agitated echo bubble study with a 4-chamber apical view. This is quite easy to perform, quite affordable, but the problem with this test, and what I would like to highlight, is two aspects. The one is it beautifully illustrates the problem with these AVMs in the right to left shunt. And you can imagine if you have a significant bacteremia, it just wonderfully illustrates how those bacteria can get shunted right into the systemic circulation, into the brain, and cause abscesses. But it's also to allude to the fact that this is a wonderful sensitive test to pick up that shunt, but it's not very specific at all. It doesn't tell you where the lesions are. It doesn't tell you how many they are, how large they are, and can you actually intervene. So it does have its limitations, but it's quite sensitive. You also need to account for if there's maybe an anomaly and an undiagnosed septal defect, that it might skew the results as well. On this slide, you can appreciate on your left-hand side what you might find on clinical examination in the oral cavity on the lips. And then on the right-hand side, you can see what you might see on endoscopic evaluation. We're not ENTs, but I would like to just show you the inside of a HHD patient's nose. You can appreciate the septal perforation already from repeated cautery on the right-hand side. And then we often send these patients to the ENTs expecting them to do wonders, but you can imagine if you go into this nose, how friable the mucosa would be. And this nicely illustrates the lack of quality of life these patients can experience, because you can imagine if you sneeze or you bend over, those things tend to bleed, and then this impedes significantly on these patients' quality of life. And it's quite troublesome from an ENT side to manage. It's not always easy, but they do have some options. So with regards to the complications, with telangiectatic lesions can cause severe epistaxis. Unfortunately, these patients tend to sit at home bleeding for 20 to 30 to 40 minutes, and they think it's all right. And that's where the patient education comes in. They can develop severe iron deficiency anemia. They have increased demands. That's most of the time suboptimally treated. And then they can develop some GIT bleeding, most of the time quite occultly. With regards to the arteriovenous malformations, as mentioned, they can get migraines with auras that can lead, and this can also cause brain abscesses. They can become hypoxic. They can even have some hemorrhage or strokes, failure, and even death. With regards to the pediatric populations, they're quite sinister. They can be completely asymptomatic, or they can jump on you with a complication of a cerebral AVM. Pregnancy can be safe and can be normal unless they maybe have undiagnosed or untreated pulmonary AVMs or cerebral AVMs. Ideally, you would want to see these patients pre-conception for the counseling and both for the screening, but you can screen and intervene in the second trimester. And then they also have comorbidities. I just want to highlight with the SMAD4 population, their polyps tend to be of varying histology, and they can develop adenocarcinoma. So screening and surveillance in these patients are quite significant, and you might see some joint hypermobility with some subluxations and dislocations. But as mentioned, this is quite a rare group. I just want to apologize for the presentation of the white onto the yellow, but that was the picture I could find. So this is the recommended screening from the Cure HHD working group for the Cure HHD international guidelines. And this is for all patients with either a positive genetic screen, 2 or more of the Curacao criteria, or 50% risk of HHT in a child, of an HHT adult, or basically anyone you have a strong feeling that this patient has HHT. So I would like to draw your attention to the left-hand side. Let's start with the little ones. So they advocate for lung AVM screening either with transthoracic echo and or pulse oximetry and chest x-ray. You can imagine that's not very specific nor very sensitive, but we do need to try and limit the radiation exposure in the little ones. And then if that initial screen is negative, you can repeat that in 5 years' time. And I would like to jump to the adults. Lung AVM screening is crucial because these patients become symptomatic. You can either do that through transthoracic echo or CT scan. I just want to highlight it's very resource and setting based. I had a wonderful conversation with one of the pioneers of HHT, Dr. Claire Chauvelin, that's based in the UK, at the most recent conference in Portugal. And I asked her, what does she think about the HHT bubble screening test? And she just looked at me and she just told me she doesn't really care how you screen for them as long as you find them and fix them if they can be fixed. If you don't have the capabilities at your center to perform the bubble echo, it's fine. Just go onto the screening. Just as long as you screen them, it's okay. If they generally repeated every 5 to 10 years, depending on the results, and if they have had intervention with regards to interventional radiology and coiling, that might differ. But you can look at the guidelines for that. We also opt for liver screening in the adults with Doppler ultrasound, but we sometimes ask our friendly radiologists to peek underneath the diaphragm. Depending on your resources, you might opt to do the same. With regards to both of them, we need to screen them for the brain AVMs with MRI, with contrast, or without contrast. If it was initially negative as a little one, you need to repeat the screening in adulthood. So then very crucial for this session this afternoon for hematology, iron deficiency and anemia screening in all adults, irrespective of symptomatology. In my experience and based on our case that was presented at the beginning, I would just opt to screen the kiddies as well. You can still have all the symptoms and all the issues with iron deficiency without the anemia. And I can't emphasize this enough. So go find the anemia and treat the anemia correctly. So look at some principles of the management. It's always multidisciplinary. As I mentioned, it's the buzzword. And then if you have access to it and it's an option, you can combine that with genetic testing. So some of the principles of management is one is to prevent morbidity from the pulmonary AVMs and the cerebral AVMs. And then is to improve the quality of life of these patients, especially with regards to their epistaxias. That's most of the time the patient's biggest issue for them. And it's impossible to, it's crucial to address that and also to treat the anemia. Neurosystemic therapies are available, none are FDA approved. The HHT group is currently running a clinical trial funded by them on pazopanib, but unfortunately that's not open to anywhere outside of the Northern Americas. So you can individualize treatment based on the phenotype. And just to note that antiplatelet and anticoagulation is not contraindicated in this patient group. All of our recommendations and management in our clinic, we try to align with the 2020 Cure HHT International Guidelines, but I have to emphasize in our setting, in our patient populations, in our austere environments, sometimes if you find them, do what you can as best as you can and refer them to a center close to you. So I would like to pause a few minutes or two on this slide. It's absolutely crucial to screen these patients for the anemia and also for the non-anemic iron deficiency. Patients tend to think this is normal. They tend to think that sitting at home bleeding for 20 minutes is absolutely normal. And this is normal and then they can't feel better. And that's wrong. These patients can be treated well. They can feel better and they can have more energy. We just need to manage them properly. So oral iron is an option, maybe in young patients with self-limiting epistaxis whom respond well if you follow them up correctly. But in our center, we advocate for total intravenous iron. A lot of these patients, especially the older they become comorbid. They mix their oral iron with continental breakfast, or they take their PPI and it doesn't work at all. These patients, you need to aim higher because they have ongoing losses. And remember, in the pathophysiology of this disease, they have absolutely, barring any comorbid conditions, they have normal functioning bone marrows. We need to supplement those bone marrows to make the blood cells to compensate for their ongoing losses. So, and I would just like to, I'm quite passionate about PBM outside of HHT. And you need to maintain your patient blood management principles in these patients. If they are unstable and they are hypovolemic, yes, go give the blood, restore the oxygen delivery capacity. But they often tend to progress into a long-standing chronic anemia, so they can tolerate lower HBs quite well sometimes. So you do have time to give them the iron. If they're unstable, give them the 1 unit and chase it with the Cosmofer and review and surveillance these patients. As I mentioned, you need to aim higher with the ongoing losses, but also to maintain clinical reasoning and assess the response. If what you're doing is not working, go look again. If the history that's given of the bleeding is out of proportion of what you're seeing on the bloods, think of other causes. HSC patients have comorbidities, they get GIT cancers, they can have other reasons to bleed. They might be ladies of childbearing age and lose major blood throughout the menses. So always maintain your clinical reasoning with regards to assessing these patients. There are some tools available in assessing the epistaxis bleeding, like the epistaxis severity score or the nose score. Feel free to contact me should you need any access to these. With regards to the ENT side, I like to think of it as a pyramid. On the base, you have good nasal humidification and patient education, both on when to use the humidification. And that's on the basis that if the mucosa is not irritated, these lesions tend to bleed less. If it's nice and moist, they tend to be more happy and they tend to bleed less. You can top that up with some oral tranexamic acid. And it's also important to educate these patients that it's not a prophylactic agent. It's an agent for ongoing bleeding. There's a good space for this in the treatment of ongoing bleeding, but it's seldomly and not really indicated as a prophylactic agent. Then you can also refer to your multidisciplinary team and the ENTs. They can opt to do any numerous of things, but the new kid on the block, and especially at our center, what we're looking at into providing these patients is sclerotherapy. It's often quite safe, but unfortunately it's still off-label. So we need to think very carefully on which patients qualify. If you're really in the sticks and you don't know what to do, you can give a systemic bevacizumab, which is an anticlonal monoclonal antibody. But it's also not registered for HST. It's quite expensive. And you can also opt for surgical intervention, the Young's or septodermoplasty. We don't actively advocate for those because they tend to not work nicely. I just want to allude to the left. You can see this is always on the backbone of good IV maintenance, IV iron, and if needed, blood transfusion. So just with regards to the pulmonary management, screening is crucial. Major cause of adverse events due to the right to left shunt. As mentioned, you can do either the bubble or the CT, and it's quite center specific. You can find simple AVMs, complex or diffuse type, depending on the feeding artery amounts and their size. And then you can refer them to interventional radiology. They can actually intervene on any AVM with a feeding artery diameter of more than 2 millimeters. And it's crucial to follow these patients up. But possibly the most important thing on this slide is to remember that these patients require IV filters to prevent air emboli, antibiotic prophylaxis for invasive procedures and dental procedures, and it can become problematic during pregnancy. They also need to avoid scuba diving in high altitudes. They might not want to climb Kilimanjaro, but they should be careful of getting into a helicopter with a non-compressed cabin. Other management options, so the brains need to be scanned and they need to be referred for neurovascular review. Some of the AVMs can't actually be fixed, so it's under specialist care and discretion. So the liver AVMs, 20% of them become symptomatic. Most of the time you can just leave and observe, but some of them do need diagnostic and definitive management, and you need to refer to specialist center. The GIT, I'm not going to look in too much. We have a wonderful colleague that will allude to that, Dr. Detlefs. Pediatrics is a high index of suspicion population. They can, if you're wondering about it and you're scared of it, go screen if you don't have access for genetic testing. You can save that little one's life. Pregnancy is a complicated thing. It can be absolutely normal, especially if the mom doesn't have pulmonary AVMs, but family planning and genetic counseling is crucial. So bevacizumab, as mentioned, is a systemic therapy that's available. It is limited in South Africa. We've tried with one patient to motivate it, for which we were able to do so. The problem is, especially in private, sometimes you get to refer them for this, and the medical aid says, yes, okay, shop, we can do this for you. But then often they only allocate enough funds for subtherapeutic doses. We do have some access to protocols for bevacizumab, but it's quite a last resort, especially in our setting. So I just wanted to draw back to the cases we started out, so we can just highlight again, knowing all of what we just discussed, that there was a massive diagnostic delay in the SMAD4 family. Unfortunately, it took 50 years for them since the initial diagnosis or the initial presentation to send away genetic testing. Might have to do with their resources at the time, but also baby M was diagnosed at post-mortem and baby L was clinically diagnosed at 19. Yes, there is some misdiagnosis, or sometimes the babies or the pediatric patients don't present well, but this little one had quite enough reason to believe that she had HHT prior. So diagnostic reasoning is crucial, and I think the bottom line is retain your curiosity. If you're wondering about a patient and something doesn't make sense, go look, phone a friend, look and see what you're missing. History is often invaluable in these patients, and if you need to go back to the drawing board, that's often where I like to start. The phenotypes differ also within the same family, and that's why treatment is sometimes individualized. So just to summarize, it's quite a complex multi-system disease, and I think screening is key, and I think that's where you save the lives. But I also think we need to, like in this session today, hopefully educate and make each other aware of this and have a good discussion on what we can improve on. If you have any questions or any concerns, just yes, have the discussion. And I think especially in this platform from hematological side is we need to look at the patient blood management principles. These patients have working bone marrows. Let's make the IV iron the backbone of the treatment then. Patient awareness is also extremely crucial. They need to buy in, because the better they manage it with us, the better the prognosis. I just want to allude you to some patient education resources that our wonderful colleagues at VADIS-A made for us. CareHHT has some, but I would prefer that you guys use this one, because it speaks to our setting and it's more individualized for the South African platform. You can feel free, that QR code will send you directly to that PDF downloadable. And for physician resources, you can go to the CareHHT website. This QR code will take you directly to the provider resources. And then for our private colleagues, I would just like to allude you to the fact that HHT is a PMB condition. So the patients are not supposed to pay so much with the medical aid for this. I would recommend, if you do see a patient, counsel them a little bit on medical aid plans. Try and see if they can get onto a higher plan. This is quite an expensive disease to manage. And there are some of the other ICD-10 codes that you might need. And then I would just like to thank my colleagues. Most of them are on this talk at the moment. Prof. Estelle Verbergen, Dr. Kritzinger has been pioneering this IV transfusion mindset from the beginning, and we've had tremendous results. And I want to thank them for their guidance and their work. And then also Prof. Leber, that's also been joining in, working hard in this multidisciplinary clinic. And it's really been shown to have good results for our center. Thank you again. If you want any references, you can just feel free, or just have any questions, you can just feel free to email me as well.
Thanks, Elzaan, for a fantastic overview. Greatly appreciate it. While Dr. Dietlefs is getting his slides ready, maybe we can just take a comment or a question or two now. I see something from Dr. Andrew McDonald. Andrew says, my experience with HHT and medical aids is an uphill battle, continuing inability to understand the need for IV iron, and trying to get bevacizumab is even more difficult. Elzaan, I don't know if you want to comment on that.
I can just, yes, I can just echo extremely well. That's very common. And I think it's not, if it's any aid to the issue, it's not a South African problem alone. There was big talks at the HHT conference, even amongst peers and in the discussions, is that it's a global problem. we've had some support and some suggestions from some of the reps, even at our unit, approaching us, telling us that they can actually assist in trying to motivate for the IV iron. So feel free to email me or just make contact with me afterwards, Dr. McDonald, and then we can see how we can assist you. We've had quite a couple of battles and we've won some of them. So yeah, we can definitely look into that. And with regards to the bevacizumab, especially with the epistaxis, again, with Prof. Leber, we are working on a couple of options prior to bevacizumab. So yeah, watch the space and please make contact.
Thanks, Elzaan. And Andrew, if it is of any help, I mean, these patients need chronic blood transfusions, as you know, and that means that they would typically get leukodepleted, which is more expensive as well. And if they don't get that, they're going to be exposed to HLA antigens over time. So you're welcome to say that at Hereditary, this is our routine. And the Elzaan and Gerdien can confirm, but almost the whole HHT cohort that we look after is transfusion free. But it does mean that they get the IV iron on a very regular basis. It's a huge cost saver at the end of the day. And patients do really, really well. And they now run mostly normal or near normal HBs compared to previously where they ended up with HBs of 3 and 4 in the ER every second or third week. So IV iron is a no-brainer for me in this population. If there's one population that I think needs IV iron as an absolute routine, preemptively, this is the population. Great. I have already introduced Dr. Dietlefs, our gastroenterologist from Milnerton Mediclinic. And Edwin, once again, thank you so much for sharing some of your expertise with us this afternoon. And you can see some of Edwin's passion here in the front as well, I guess. So Edwin, over to you.
Thank you. Thank you, Vernon. I just want to check. Can you hear me? And
we can
you
hear
see
you.
The talk?
We can see
Great.
it. Thank you.
Thanks, Vernon, and Elzaan. Thanks for the invite. So Elzaan, you did very beautiful presentation on very complex cases. My case is going to be very, very basic. I'm going to present a case presentation of what I think is a sort of common variety type HHT, but I think still interesting, and there are some important learning points there. All right, so the case I'm going to present is a 60-year-old male that first consulted with me in 2020. He was referred to me by his physician with a 4-year history of recurring iron deficiency anemia, never massively overt GI bleeding, a couple of spells of melena, but nothing more than that. His HB dropped down to 6.7 at its lowest, and he's always had a clear iron deficiency with a ferritin of 3 at its lowest. And up until when I saw him, he was managed with repeated admissions for blood transfusions. He had numerous gastroscopies and colonoscopies and CT scans, which were all pretty unremarkable. No telangiectatic or angiectatic lesions. A large hiatus hernia was an incidental finding. And he was referred to me for investigation of his small bowel to look for an occult source of bleeding in the small bowel. And as you might or might not know, the small bowel capsule endoscopy is the best test to look at the luminal surface of the entire length of the small bowel, and there are several products on the market, Pulcam being the leader. So basically what it entails is a little camera that looks like a big vitamin pill, a sensor belt that you wear around the waist. Connected to that sensor belt is a data recorder, and once the capsule is activated, it starts taking pictures, gets sensed by the sensor belt, gets stored in the data recorder, and at the end of the day, all this information is downloaded and read via software. It's an outpatient procedure. You come in the morning, swallow the camera, go home, and come back at the end of the day. And that's what this patient had. The reason why we do a capsule endoscopy is firstly, in a lot of cases, to exclude anything sinister and to give some reassurance that nothing more needs to be done apart from supportive management with intravenous iron in most cases. But it also tells whether there's something that can be intervened on. And in that regard, we then do a small bowel scope. The one that's most commonly used is something called a double balloon scope. And this is what it looks like. And this is the schematic. And basically what you have is two balloons that gets inflated and deflated sequentially. And in a push and pull maneuver, you then are able to pull the small bowel over the scope and examine large lengths of the small bowel. And if you're lucky, maybe the entire length of the small bowel, which, as you know, might be up to 5 to 8 meters in length. And you do this by a per oral or antegrade approach through the stomach, or a retrograde or per anal approach going through the length of the colon and then up into the small bowel. So this is my patient's capsular endoscopy result. So as things go in private, and probably in the state as well, I didn't see this patient beforehand. I consulted with him telephonically and made sure the capsular endoscopy was indicated. My nursing sister did the setup, and I read the study and then rang him with the results. So these are some key images. They're not particularly pretty, but this is real life. So the image on the left is in the stomach. The black is altered blood, so basically melena. Image in the middle is more of the same, so altered blood or melena. And then on the right-hand side, in the green circle, is an angiectatic lesion. Not that clear, but again, this is what it looks like sometimes in real life. So I then arranged for a gastroscopy, because the angiectatic lesion or telangiectatic lesion, we use the terms interchangeably in GIT, showed that the biggest lesion, only showed one lesion, was in the duodenum, so quite in reach of a gastroscopy. So we didn't think that a double balloon enteroscopy, a deep small bowel scope, was necessary. And in the left pane, you see this angiectatic lesion. It looks like sort of a spider web of blood vessels. This is not an AVM, so there's not a communication between venous and arterial, but it's just a dilated blood vessel, either an arterial or venial or capillary. So that was the big lesion that we saw in the duodenum, but then he also had one tiny little lesion in the stomach, and lots of these, about 10 of these tiny pinpoint-sized lesions on the right-hand side, deeper down in the small bowel. And what we do through the scope is that blue probe is an APC probe. It stands for argon plasma coagulation. It's basically a cautery device that uses argon gas, and the advantage there is that you burn very superficially. And in most cases, that's what it looks like on the right-hand side after treatment. But most interesting, on this gastroscopy, I also noticed on the left pane telangiectatic lesions on the tongue, and on the right-hand side, telangiectatic lesions on the palate. And then finally came the examination, long overdue, and this is what my patient's tongue and face looks like. These are more recent pictures which he sent me. It wasn't this obvious initially, but it clearly has lots of telangiectatic lesions on the tongue and all around the face, forehead on the right-hand side. And you can see it looks pretty much the same as it does in the intestinal tract. These are the other common sites, fingertips, both dorsal and lateral. So at that stage, I went back in retrospect and asked directed questions. And yes, there was a long history of recurring nosebleeds, recurring epistaxis, requiring multiple ENT interventions in the past. I decided to do further imaging. He didn't have any AVMs in the liver or the lungs. I did not do cerebral imaging. In retrospect, that's probably an omission. But by that time, the QHHT guidelines had not come out. So I could then fairly confidently tell him that he has HHT. And from that point on, we actively manage him, meaning we checked his hematological parameters on a regular basis, prophylactically, made sure that he got lots of iron, and he required no further admissions, no further blood transfusions. And on average, he required 1 or 2 monofit total dose infusions a year. Also decided not to do any further scopes. He was not a SMAD4, and clinically it wasn't indicated. And he had a good quality of life until, unfortunately, in June this year, he was diagnosed with metastatic cancer of the gallbladder. This, unfortunately, is bad luck. I don't think it's related to his HHT. Just to echo Alzan's point that HHT patients get other comorbidity as well. So he's currently undergoing chemotherapy. Unfortunately, it's not a resectable cancer. So just in brief, Alzan has actually mentioned all this already. So the GI bleeding occurs in up to a third of patients with HHT. It can be overt. I must say in most cases, these patients don't have massive bleeds. They either have a bit of melena or more commonly, they just present with a recurring iron deficiency anemia. The GI manifestations occur after the epistaxis, as Alzan has mentioned, and usually only after the age of 40. And as I've said, it's due to these angiectatic or telangiectatic lesions. They're most common in the stomach and in the duodenum, and usually in the first part of the duodenum. So it's rare that these patients need small bowel scopes. Most of these lesions, if you do a detailed examination, are reachable with a standard gastroscopy. You can also get these lesions in the colon, but that's less common than stomach and small bowel or duodenum in particular. If there's overt bleeding, so a lot of blood, hematemesis or fresh rectal bleeding, then one should think about other causes, polyps, AVMs of the GI tract, which is fortunately quite uncommon. And then it is, despite the angiectatic lesions being quite common in the intestinal tract, it is actually thought that epistaxis or unrecognized epistaxis is probably a more common cause of an iron deficiency anemia than the GI bleeding. I've purposefully not discussed AVMs and SMAD4 because that is a particularly complex topic which Alzan has already spoken about. So just in short, I think there are some missed opportunities in my patient. So obviously, as is quite common with HHT, there was a delay in a unifying diagnosis. But in retrospect, it could have been made much earlier. The recurring episodes of epistaxis that predated the GI bleed by many years, the quite obvious mucocutaneous telangiectasia, the visceral involvement, which in the end was quite obvious, and I'm quite sure it was missed on numerous gastroscopies in the past. And then the other major missed opportunity is suboptimal treatment of the iron deficiency anemia. And this patient didn't need blood transfusions as needed proactive monitoring and liberal administration of total dose iron infusions. And again, I also emphasize the PBM principles. So my take-home messages is, yes, it's a complex multi-system inherited disorder. The clinical examination is still useful. We shouldn't just be behind the scope and look at the slides and the numbers. We actually need to examine, especially for mucocutaneous telangiectasia. The GI bleeding can be investigated and can be treated, but it's often of secondary importance to the epistaxis and AVMs in terms of iron deficiency anemia and life-threatening problems. On the other hand, I also think we should caution against over-investigation of the intestinal tract, as the mainstay of treatment here is intravenous iron and liberal doses of it. And I think that is me. Thank you.
Thanks so much, Edwin. Fantastic. Well, once again, to get your take on this. And by the way, if you have difficult patients with unexplained GI bleeding, Edwin is your man. He can do quite remarkable things with those scopes of his. So thank you for sharing that. Thank you also for the nice videos and images that you shared. There is a question here in the meantime from Prof. Marius Kutsia. Do patients with HHT ever develop vitamin B12 deficiency with their active erythropoiesis? Marius, that's a good question. I've not personally seen this. I don't know if Alzan or anybody else would like to comment. Fortunately, we typically have a few years worth of B12 stores, but it is true that if a patient's got an inadequate diet, it's something to think about. I haven't personally seen any patient with dual B12 and iron deficiency that wasn't otherwise explained. Elzaan, have you seen, or Gerdien, have you seen any cases such as this? Or anyone else?
I can only speak in my very limited experience looking at our cohort in the last 2 years. And I can honestly say we've had, knowing that you need to think of other things as well, we have had some sporadic incidences where we actually did investigate the B12 in our HHT cohort on selected patients based on what we could see, and what we see on the bloods are not in keeping with what the patient is telling us based on the bleeding history. And the sporadic ones we've seen actually never had B12 deficiency. I think we've had one patient once that had some supplementation, but we couldn't see a clear correlation in our cohort of vitamin T correlating to low HBs in anemia with a higher increased or raised MCV. And I can't actually recall anything in the literature, but I don't think we should exclude it based on the physiology and the possibility. I think, but again, it brings us back to the point is HHT has friends and it has comorbidities, and we should not miss those.
Great. I've done a quick PubMed search here on B12 HHT and B12 Osler-Weber, Rendu, and nothing appears to come up. So there's maybe an option for further investigation and an MED for somebody. Good. So I think we're going to move on to our third presentation. Can I just hear, is Professor Libbe in the audience yet? She's actually on her way to...
Yes, Vernon, I'm here.
Okay,
I've got
fantastic.
Another half an hour before I board, but I'm sitting here waiting,
Well,
listening.
Darlene, we just want to say a special welcome to you as well. We are so fortunate to have all these amazing people in the meeting today, and thank you for joining us from the airport in between your boarding and everything. Darlene has been a phenomenal partner for us in helping us manage these very complicated ENT patients, and she's done it with so much passion as well. And we're also excited about the study that we referred to earlier that we'll be doing, well, that she will be doing, and we will be supporting with Elzaan and the rest of the team. So great stuff. Thanks for coming in. Darlene, maybe just to make sure that we don't miss any input from you, before I give Prof. Coetzee the floor, do you have any comments that you'd like to maybe make just from an ENT perspective in your experiences, maybe one or two things that you'd like to highlight to our audience today, and just say things that people need to consider or think of and look out for, maybe your experience with the Young's procedure? Yes. Sorry,
Yes,
I didn't
sure.
warn you beforehand. This is now, I'm putting you on the spot here.
No, perfect. I missed the first couple of minutes of Elzaan's presentation, but I can really say that this has made, your clinic has made such a difference to the management of our HHT patients. I've been doing this clinic now for our ENT clinic for almost 20 years. And the HHT patients were really a very difficult group of patients to manage. And usually we would offer them septodermoplasty. I've offered one patient a Young's procedure and actually had to reverse it. They were just not coping with the fact that, that they couldn't breathe through their nose. So the one thing that's made a massive difference is the iron transfusions. We used to see and admit these patients on such a regular basis in the ENT ward for transfusions and for regular packing. We never cauterized. I always just did the septodermoplasty, which seemed to work well for 6 months, but then you need to do the opposite side. One of the most revolutionary things, and I'm not sure if Elzaan mentioned this, is a study on the bleomycin injections for these patients. So she's presenting at our Congress now a group of 5 patients, 3 of them done years before, and 2 very recently, 2 very, very difficult to manage epistaxis patients that have been lying in our ENT ward for a couple of days with the nasal packs. And as soon as you remove these packs, these patients started bleeding. So we use the bleomycin on a compassionate basis, and both these patients, I actually spoke to the one lady today. It's revolutionized the way that they kind of live. They're able to go outside, do normal things. They used to suffer from daily severe bleeds. So I'm very, very excited about Elzan's project on the bleomycin, and hopefully we'll be able to kick off the prospective study really soon. So I just want to thank you for including me in your HHT group. And I think it's really exciting, and you've made such a difference to the HHT population in Cape Town.
Darlene, thank you so much. And if this is one important takeaway of the day, you cannot treat HHT without friends. And like Elzan was speaking about, the friends of the Telangiectasia, that we need to consider all the other organ involvements. You need your friends and a multidisciplinary team, and it's absolutely worthwhile for those patients to have people that get interested, that get the experience. We were fortunate to have Prof. Liver, who's a world-renowned ENT specialist and who's already had all that experience, but you need to build that local expertise. And I think if your ENTs, and I hope I can say that, Darlene, on your behalf, but if they need advice, really, they must contact the Groote Schuur team and contact Prof. Liver, because they really have built up such phenomenal expertise that we find has made all the difference to our patients. Thanks, Darlene. I appreciate those comments. And now over to Prof. Marius Coetzee, who I've introduced already. Marius, lovely to have you with us again. And we look forward to your practical experience on managing HHT in Bloemfontein.
Thank you. I've simply, thank you very much, Vernon and the Blood SA team for Elzan and Dr. Dietlef's so I've got 10 slides. The first one is, how would our patients actually in the central part of the country differ from those in Cape Town? So, well, we went into some of the family histories quite deeply, but couldn't go so far as to identify ancestors in the Cape, which kind of supports the idea that HHT occurs in all sorts of populations right throughout the world. The other thing is that central South Africa is much drier than the Cape, and I wonder if there might be some phenotypic difference. Our patients sometimes bleed worse in the summer when it's hot and dry, and sometimes when it's cold and dry in the winter. And so far, sorry, just one thing, we haven't needed much interventional radiology in our small group. So the thing is that there were these HHT patients with worsening iron deficiency in the hematology clinic, which sparked our interest. So it kind of moved from iron deficiency to this vascular disorder. And some of our attempts were really abortive at first, but at least we've moved to get some of the families genotyped and looked at the mental health of some of the patients. Depression is 30% plus in our group of HHT, and then we looked at whether masks actually worsen bleeding symptoms or not. But at the moment, we have plus minus 25 patients on the books. 15 of them are seen regularly, and it's just kind of grown in the bleeding disorder clinic, and they get seen in between patients with hemophilia and von Willebrand disease and so on. And we really appreciate the help from clinical hematology, Jacques Malherbe and Caroline Stein, for all their cooperation and admissions. On an ad hoc basis, we work with ENT, radiology, and peds cardiology. Peds cardiology does the bubble scans for us very effectively, and we're glad about that help. We try and follow the 2020 HHT guidelines, with the Curacao criteria, ENT workup, chest X-ray and bubble test, a brain MRI, and at least an abdominal sonar to give a rough idea of what's going on in the liver. We tend to do the epistaxis severity score at each visit as some kind of indicator of whether we're winning or losing. And we just access it through Cure HHT's website on our phones. And then one of the legacies of Prof. Lowe is our infusion clinic. I think we use more iron than anybody else in the hospital. And so all of the patients get iron infusions except occasionally. So what have I come to realize over the years? The first thing is that HHT is much more common than hemophilia. And as we, and I'm certain this is the same experience in other centers, as we start collecting them, they start appealing out of the woodwork. It's kind of labeled as an autosomal dominant condition, but there's actually a significant interaction with the process, with the environment, a kind of a second hit process. So as Alzana's mentioned, kids don't often have all the Curacao criteria, but this appears. There's with time. There's a lot of clinical variability, and there are many gene pathways. And then HHG genetics is not something you can dabble in occasionally. You really need a good service. And I'd like to hear from you guys. And then this is the, of course, the second HHT management guideline. So the first thing we try to do is to stop the bleeding. Most of the patients simply put in Vaseline with their into their nose with their fingers and find this helps a lot. Some of them do saline douches also, and we've been pushing tranexamic acid up to what the randomized controlled trials mentioned in the guidelines use, about 3 grams a day. And in a lot of patients, this works remarkably, except if you go to the higher doses, some people develop headaches, and then we just bring down the dose. The other thing is also the importance of a very good history. TCAMS is for traditional, complementary, and alternative medications. One lady was bleeding herself almost to death until we discovered that she was using grandpas almost daily. And now it's going much better. The important thing of looking at all the systems. We've tried little things, and I'm very interested in the bleomycin, but, sorry, let me just get back to where I was. Oral propranolol, but it's not a great success. Doxycycline has also been shown by randomized controlled studies not really to work, and it seems to benefit one patient. We've kind of been forced to start tamoxifen because our PTC refused to give us bevacizumab. and I'll talk about that a bit later. Of course, I remember that Vernon had a catastrophic thrombosis on somebody who was using tamoxifen. Right, so with iron replacement, we use Cosmofer because it's freely available through the state. And just the important things we administer, whether it's 500 milligrams or 2 grams, all in 200 milliliters of saline, to prevent the free iron radicals actually leaving the carbohydrate shells of the drugs and then causing hypertension and other symptoms. We've been trying to train district hospitals to give Cosmofer. So there's one at Jagersfontein that does it regularly for us, which is tremendous. And they actually keep it in stock. Other hospitals, we've made a compromise by actually issuing the Cosmofer to the patient to take home and then have it 2 weeks later. We've continued with oral ferrous sulfate 3 tablets a week for what it's worth. But one of our confounding problems was we have a family with a specific endoglobulin mutation, and these people bleed profusely if you give them a Cosmofer dose of about 400 milligrams or more. And it seems to be to occur in other places of the world. And we now have a project with Claire Chauvelin to work out what is lying behind this. Because, you know, you'd like to give them a gram of Cosmofer, but when they come sort of crying that they've bled out it all within about 48 hours, you're not really winning. Okay, so I'm just going to mention 3 of our problem cases. This is the first one is a 70-year-old man who cannot tolerate high doses of IV iron. He's got increasing epistaxis with recurrent admissions with hemoglobins about 4 to 5. Okay, I've mentioned the iron. He has no radiographically detectable pulmonary AVMs because we did this as a precursor before motivating for bevacizumab. However, we will, so our PTC said in the end, try tamoxifen, and if that doesn't work, we'll pay for the 100,000 Rand bill for about a year of bevacizumab. There are some indications that people with factor V laden tend to get more thromboses on tamoxifen, and so we've done that for him. We haven't got the result yet. The second is a 34-year-old female with a significant iron requirement. But also she can also not tolerate more than about 400 milligrams of Cosmofer at a sitting. She's got hepatic AVMs. There's some story that somebody tried a partial embolization a few years ago, but of course, embolization of hepatic AVMs can cause massive hepatic necrosis. So we actually need to motivate for bevacizumab because this seems to work fairly well in pulmonary AVMs. So she's never been pregnant. And we've just had 1 or 2 experiences with pregnancy, but the women luckily didn't have enlargements of their CNS AVMs. And then a 48-year-old female. She actually initially improved tremendously on tranexamic acid and IV iron. A gastroscopy showed some telangiectasias, and we tried a PPI. but she's been bleeding profusely, and because of some crisis, in the family, I gave her fluoxetine, and I'm afraid that I think the fluoxetine is actually paralyzed the platelets because of the dual pathways. So we're going to try and reduce that. And then just lastly, about once in 2 to 3 months, we might get somebody who needs a transfusion. But even with patients of HbS 4 to 5, we just, they come to the clinic, say on a Thursday, we load them with Cosmofer and order a unit of blood for the next morning. And they start feeling better after the Cosmofer, and after a single unit, they're very happy to go home, to come back in 2 weeks or a month. Thanks very much. Over to the discussion.
Marius, thank you very much. This is why hematologists should never retire, is because of people like you and Cecile and others that bring this remarkable practical expertise to the table. Thank you so much for that. That was really wonderful. Can I ask for anyone for some inputs? I thought this was really interesting. Can I also ask Estelle? I'm sure Estelle is here in the audience, to maybe just share some of her own thoughts. She's been very instrumental in putting this whole clinic and the multidisciplinary team together. Maybe Estelle, you can just comment on the other team members that form part of this. And yeah, welcome any questions.
Yeah, I can give a few comments. I think, yeah, I just loved the presentations today. It's something very near to our heart. Marius, it was amazing to see what you guys do in Bloemfontein. And the multidisciplinarity of the clinic, I think, has been pointed out. It makes such a difference. And the proof of the pudding is in the eating, really. What I mean by that is we can see how the clinic in Bloemfontein grew, quite a big clinic for the Free State, and our clinic has also grown. And we also we've looked at certain things like late diagnosis and family history taking, and really speaking to possible new family members. And it can make a huge difference, because as Alzaan shared, people just think this is the way it is. Patients think there's nothing much anybody can do for them. And it truly makes a huge difference if they come into a clinic where they are being supported. And Gerdien is the one who started this clinic with me and a few others, and the multidisciplinary team, as Prof. Low as Vernon is saying. We started this just sort of in the COVID time, just in that time, and it made a huge difference on blood use for these patients. And for many years before that, on my own, I tried, and all of us, Cecile, we tried to give more iron and less blood. And somehow it took Gerdien, who looked after these patients for the first year solely. It took her incredible detailed attention to these patients and the access, Andrew, that we happen to have in public service to intravenous iron. That's the one thing we have. And we can access it. And it took that very, very focused attention to truly turn around the blood dependency these patients had. And then all the wonderful other things that has been shared by Alzaan, by the gastroenterologist. So we hope to start in the new year with another, thanks Andrew for your, we hope to start with, we're going to chat about the other findings we saw and about other ideas of what's coming out of the clinic. So.
Thanks, Estelle. Yeah, we're looking forward to that. There's a couple of MED projects that have come out of the HHT clinic. and we look forward to more to come. Andrew McDonald, you've got your hand up. Please go ahead.
Yeah, so just to comment on my comment, it's not that we can't get it. It's convincing medical aids to give someone who's got a hemoglobin of 10 or 11 IV iron is actually, I mean, it's really a uphill struggle. We get it, but it's just, it takes ages to convince someone who has no idea what they're doing. They're going by rote formula for normal iron deficiency and then start reflexly saying no. Actually, Elzaan made a very interesting comment, a throwaway comment. I'd like to ask her about it because this year we've actually had two patients. One where it was a referral from Nelspruit, who he already actually had multiple pulmonary emboli. He had a clotted portal vein, mesenteric vein thrombosis, and actually we were trying to access bevacizumab for him as well as anticoagulate him, etc. But he actually died back in Nelspruit before we got all of that right. But currently, I've actually got another guy who's just had coronary stents for severe coronary atherosclerosis and symptomatic angina, and of course now on both on clopidogrel and aspirin. So it's just like really just happened about 2 weeks ago. So really waiting to see what the outcome of that is. But you mentioned kind of not a contraindicator, but I mean, obviously I would imagine that would increase the bleeding and the needing for intervention. So we'd be interesting to hear a comment on people needing, because I mean, if we keep these people alive for longer, these things are going to pop up. So much the same we're seeing in the hemophilia community. You control the bleeds, get people through to older age, and then you hint all the problems of older age as well.
Thank you, Andrew. Elzaan, do you want to make a comment on that?
Yes, thanks, Andrew, for the comment. So what I alluded to is what they're advocating. So this is something that's been debated and debated again at some of the conferences I've attended to. And I think what we really need to realize is, with regards to that, is we need to keep it patient specific. I think I don't have a lot of experience and I'm not a specialist, but I can speak to, it's a scenario where you find yourself, you're in a deep blue ocean. Should you give the anticoagulation and they bleed a lot? And I think it really kind of draws us back to the work we're trying to do with Darlene as well, is trying to close the tap. Because if you can control the bleeding per se, then the need for or the severity of the bleeds become less. And I think that's possibly what we can see in the bleomycin. I think it might be a game changer, but to be very honest with you, the international group still advocates it. I can send you a copy of the, I just quickly peeked again, that it was based on expert recommendations, and it was quite of high evidence, but they did advise to avoid dual antiplatelet therapy or a combination of antiplatelet therapy and anticoagulation where possible. So again, it draws back to it's patient specific. I think we need to have open discussions with our patients with regards to the pros and the cons of what we can and what we cannot do, and make them part of the conversation. But in all honesty, my short answer is I don't have the answer yet, and I think the international community doesn't either. But I think there's a wonderful forum that I think we should open the discussion on with the HST colleagues abroad and just revisit the subject. But I think hopefully if we can get to a point where we can close the tap with, let's say, bleomycin, for instance, that problem might become less of an issue moving forward. Because like you said, we are keeping these patients longer, alive for longer. And they, but unfortunately, I don't have a nice academic answer for you.
Thank you for that, Elzaan. I think the one thing I'm taking away as well is a comment made that HHT is more common than hemophilia. If I look at the 400 and something hemophilia patients we have in the Western Cape, and we've got 25 or so HHT patients in our clinic. I'm not sure how many HHTs are around in the rest of the Western Cape, but I would imagine that most of them will be at Tygerberg or with us. then I think we've got a long way to go to diagnose them. And I think the case finding by screening families has been a very important way for us to find new patients. And it's exciting to see the research being done by your team, Marius. A couple of studies here, and hopefully we can put our strengths and our numbers together at some stage and really put out something that is more representative of the whole country, and maybe some others would like to join in. But it sounds to me like there's still a lot to do in terms of finding cases and diagnosing them. I want to just say, I see Jasmine Ramaya, as just mentioned here. Thank you for such fantastic, insightful talks this afternoon. Well done to the team. Yes, I can just echo that. Thank you, Elzaan. Thank you, Edwin. Thank you, Marius. Thank you, Darlene, Andrew, everybody else, Estelle, that's made comments, the EMS, the Blood SA team, Gerdien, all of you. Thank you so much for a great, wonderful afternoon. It was really top quality, something one would have had to go to a very, very good conference to get anything similar, and really practical. And I hope that we could have some links to some of these resources on our website, which would be really fantastic. Sorry, there's two more comments here from Gerdien. We've also seen that as the HP increases with regular iron infusions, the epistaxis decreases and ultimately quality of life improves. Yes, there is that interesting link between hemoglobin levels and platelet function and bleeding. And of course, there's also interesting things about iron and platelet function in itself. Tabisu Rapudile, thank you for the informative talks. Thoroughly enjoyed it. Wonderful. And same with Angeline Molloy. Thank you, people, for all the good comments. Please give us that feedback form at the end. We really would appreciate 2 minutes of your time. I think actually it takes 1 minute, but let's give you 2. And we look forward to seeing you again next week. I've already seen the program for next week. It looks amazing. It looks like there's so much excitement about next week's talks and topics. And then I think we're going to have 6 or 7 different talks in one 1.5 hour session. So please make sure you've got it in your diary. We'll see each other again next week. Safe flight to you, Darlene. Thank you again, everybody, and a lovely evening further to all of you. Bye-bye.
Thank you very much, Vernon, and thank you to all the speakers. And thank you to everybody who was here. It was great.
Thanks.
Thank you very much. Bye-bye.
Thanks.
Thanks to everyone.